कैमरा साइलेंट कर लो ना।
चुनाव दुपट्टा था मैंने वहीं से लिया था।
Hello, everyone.
Hello. Hi, Amy.
Hi, Taiba. How are you?
Good. How are you?
Good. Well, thank you. Sorry, we're a bit late joining. We're just coming straight from another meeting. I don't know if Karina's joined.
Not as yet.
She's on her way, so if we just give her a minute.
Sure.
Lovely to see so many people.
Yes, some university students are also attending, Amy, both
Fantastic.
from
Well,
Lahore and Rawalpindi.
we'll just give 2 more minutes in case Karina's having issue logging on. And if necessary, I'll just make a start because then at least we can keep to time as well. But we'll just give her a couple of minutes.
Hi, Amy.
Hi, Zainab.
We're waiting for Karina. Very well, thank you.
We're
How are
just
you?
giving Karina a minute to join and then we'll make a start.
Sure.
Assalamualaikum, ma'am. Faria here. How are you, ma'am?
Very well. Thank you, Faria, for joining.
Thank you, ma'am.
Assalamualaikum, ma'am. Kiran here.
Join us today. So we have people from University of Karachi and NUST as well, and and other members too. There people too.
I'll just check with her that she's okay getting in. Okay. Taiba, I'm just thinking, shall I make a start? And if I've sent a message to Karina, I think she might be having a problem logging on. I don't know if you could just check with her if you can hear me, Taiba.
Let me check with her. Let me send her the meeting link again.
Fantastic, thank you. And I'll start, and then we're not keeping everybody waiting. So I'll share my slides. Okay. Okay, so welcome everybody. Lovely to see so many people. Thank you very much for coming today for this introductory session to low intensity cognitive behaviour therapy intervention for anxiety and depression. My name's Amy Blakemore. I'm a senior lecturer in mental health from the University of Manchester, and I'm co-leading the capability building work package for our grant with Pakistan Institute of Living and Learning, moving on ABC, developing interventions for women who are living with depression after breast cancer. We're joined hopefully shortly by Professor Karina Lovell, who's Professor of Mental Health at the University of Manchester. And we're both heavily involved in developing and evaluating low intensity cognitive behaviour therapy interventions. Today will be a general overview to low intensity interventions, the nature of those interventions, how they're delivered, and some examples of individual interventions that fall within the category of low intensity CBT interventions for anxiety and depression. Later on, if people want to, we can do a second session looking at specific adaptations around delivering these interventions for people with physical health problems. And we can think about that as our programme of research moves on as well, and sharing what we're learning through moving on ABC and the other programmes that are ongoing with Pakistan Institute of Living and Learning as well, around burns rehabilitation and cardiac rehabilitation too. Okay, so what we hope to cover today is to give you an introduction to low intensity interventions, talk about what they are, who they're for, and who delivers them. An introduction to understanding some of the assessment process for low intensity interventions, and goal setting and developing problem statements, which are a key element in cognitive behaviour therapy. Thinking about the conceptualisation or formulation of anxiety and depression for treatment using low intensity interventions, using the model that we commonly use here in Manchester, which is the ABCE model for anxiety and depression. An introduction to some of the individual low intensity interventions that can be used for anxiety and depression, and potentially an opportunity to have a go, but we'll see how time goes throughout the session. There's a lot of us here as well, so that might not be possible today, but we could think about that on another session if necessary. I'm very happy to take questions. I'll try to remember to stop every now and again and ask if anyone has any questions. You could also put your questions into the chat if you like, and I'm sure somebody will kindly have a look at those and let me know every now and again if there's any questions to be answered. So please do share your thoughts and ask any questions as we move through the session. Okay. And I believe we're together for around about 2 hours, probably up to 2 hours this afternoon, this morning. I will also plan in a break as well, just to give people a bit of a comfort break as we get halfway through. Okay. So first of all then, a question for you, which you could either type an answer into the chat or put your hand up. I don't know if someone can have a look and let me know if anyone has got their hand up. just to get an idea of what do you understand by low intensity CBT interventions? What do you think that they are? And do you have any experience delivering or involved with low intensity CBT interventions at all? Just give people a minute if they want to put anything into the chat or raise their hand. I can see somebody has their hand up.
Samia Shahid.
Samir. Thank you, Samir.
Hi, I would like to answer this question. I think
Thank
low
you.
intensity CBT intervention are delivered by non-psychologist or health professional, and they may be delivered by any other persons. And number of sessions and duration is less than high intensity CBT sessions in low intensity CBT.
Yes, thank you. Brilliant. Absolutely right. They can be delivered by non-psychologists, non-professionals. They tend to have a shorter duration and obviously intensity to the high intensity CBT interventions that we might be more familiar with. Here in the UK, they are delivered by non-professionals. They're also delivered by a specific role within the National Health Service here, psychological wellbeing practitioners who sit within our National Health Service talking therapies for anxiety and depression delivery. And they are often psychology graduates, so they've done their bachelor's degree in psychology, and then they come back to do a 1-year postgraduate training in the delivery of low intensity CBT for depression and anxiety. However, that role is not just limited to psychology graduates. It also is open to people who have experience in a different area. So sometimes that could be in mental health. So sometimes it might be people that have worked in counselling, that have worked in nursing, for example, or occupational therapy. And they may have almost a career change, if you like, and access postgraduate training in low intensity CBT interventions. It's also open to people at an undergraduate level. So people who have significant experience working in services, for example, maybe in charities, supporting people with mental health problems, can take the course at a kind of undergraduate level as well, because it's more so focused on the delivery of the intervention rather than the kind of academic requirements around that. There's also good evidence out there that it can be delivered by lay people, non-professional, non-traditional providers, we might say, with very limited experience. And certainly myself and Karina have been involved in training, for example, cadres in Indonesia who are similar to, I would say, lady health workers in terms of their role within their communities and their role in supporting healthcare within their communities. And we've certainly been involved recently in training cadres to deliver low intensity CBT interventions. Okay, I can see some points in the chat as well, but I can't quite get to them at the moment. I don't know if there's anything anyone would like to summarize from the chat for me. Because I can see it. Here we go.
I can read it, Amy, for you.
Oh, thanks, Taiba.
So Rabab said low intensity CBT is for mild symptoms and can be delivered by professionals other than the mental health professionals, clinical psychologist. And then Farah said it's a type of therapy that provides brief, focused support to individuals and often in a self-help or guided format. Then
Fantastic.
Mahjabeen said it can be delivered by community workers, lady health workers, people who are not doctors, but they can be trained by specialist trainers.
Brilliant. Thank you. Yeah, all spot on. And I think the additional thing that we hadn't already discussed there was delivery for milder symptoms. And yes, that's absolutely true. We're looking in delivery of low intensity interventions for people with mild or mild to moderate depression and anxiety symptoms. Although what's interesting to note is that although people may have milder symptoms, it doesn't necessarily mean that they are without complexity, because we're all complex people, aren't we? And often there still is a level of complexity in delivery of low intensity CBT, but we would look to reserve it for people with mild to moderate symptoms of depression and anxiety. Okay. So you may be familiar with the step care model. As I think people perhaps will have seen this before. It's basically a model for delivery of interventions for people with mental health problems, starting with the least intrusive and intensive interventions first, and then using a system of stepping people up to receive higher intensity, more intensive treatment if they do not respond to low intensity treatments, or if they set out with more severe symptoms to start with. And low intensity CBT sits at step 2 in the step care model. So where people are experiencing persistent sub-threshold depressive symptoms or anxiety symptoms that are mild to moderate, as we've said. And then we have our kind of what you might think of as full CBT, high intensity CBT, for example, at step 3. And then at step 4, we'd be looking at more treatments for more severe and complex depression. Medication can be included at any step. It's listed here from step 3 onwards, but and step 2, sorry, I missed that. But medication can be running alongside these interventions at any step if people feel that it's beneficial to them. But generally we sit at step 2, and people may experience their low intensity CBT treatment and recover and move back down to step 1, or it may be that at the end of their step 2 treatment they're still experiencing symptoms and they are stepped up then to receive high intensity CBT. There we go. So thinking about then what the key differences are between high and low intensity CBT, and some of those you've already pulled out in the comments that you left in the chat earlier. So one is the clinical method, that low intensity CBT is always supported by guided self-help. So supported by the practitioner who is really acting as a guide or a coach to support the participant, the patient, to engage in guided self-help using evidence-based low intensity CBT interventions. Somebody already mentioned as well about therapeutic dose, I think. So often for low intensity CBT, we'd be looking at a much shorter length of treatment, maybe 6 to 8 sessions. Usually it's around 6. Whereas for high intensity interventions, you might see something more like 12 or 16 or even more sessions than that in the delivery. There is a difference in some ways in terms of how low intensity CBT practitioners are trained to work with formulation or conceptualization of patients' symptoms of anxiety and depression. And with low intensity CBT, we would very much be focused on what's happening in the here and now, rather than using any longitudinal CBT formulation. We also work with single strand interventions in low intensity CBT rather than multi-strand interventions. Not to say that within a 6 to 8 session phase of treatment, patients won't work on more than one intervention, but we would be working with one intervention at one time. And obviously differences in the workforce that you've already teased out. in terms of it being suitable for delivery by non-professionals, not doctors, non-traditional providers, and lay people as well. And in terms of modes of delivery, the evidence out there demonstrates that low intensity CBT can be delivered as with full CBT using various different formats. So it can effectively be delivered face to face, which was a very traditional way here in the UK, although now treatments tend to be delivered more often online using video call or over the telephone. Also can be very well delivered in group and workshop environments as well. So it can lend itself and suit itself to many different delivery methods. And actually now many of our patients prefer the online video call delivery or telephone delivery as it's acceptable and feasible for them to engage in, fitting it in, for example, around busy lives, making it more accessible. Okay.
Sorry,
And as I
Amy, I'm
said,
here now.
oh, hi, Karina.
Yeah,
You
sorry.
okay? Did you get in okay? Yeah.
It was because they'd reached the maximum number of participants by the time I got in, so it wouldn't let me in. Yeah. So just tell me when you want me to do something and
I've just made a start, so I thought perhaps if you want to jump in when we get to the BA bit, is that okay?
Yeah,
and then,
yeah.
Is that all right? Yeah. Okay. So with low intensity CBT, as I've said, is always supported by guided self-help materials. There are lots of guided self-help materials out there. I've put a couple of pictures on here of examples of, there's a book there, there's a specialised manual there was developed within a research programme at the University of Manchester. It's always supported by guided self-help and workbooks for the patients, workbooks for the practitioners to guide that delivery. And that's all about supporting people to learn the tools and skills for themselves to help manage the symptoms they're experiencing. And I know often patients find this really, really useful in that at the end of sessions, once they've worked themselves through a workbook, they've got that there to refer back to in the future to help prevent relapse prevention, to help prevent relapse, and to help prevent reoccurrence of their symptoms as they continue on after they've received treatment. So, bit of just an overview summary here of the things that we've mentioned. What low intensity CBT interventions are: single strand interventions, usually delivered in 6 to 8 sessions, can be delivered one-to-one in a group, over the telephone or online, always supported by guided self-help, collaborative and patient-centred, and we'll move on to think about that a little bit more when we start talking about assessment and goal setting and developing collaborative problem statements in low intensity interventions. For people experiencing mild to moderate depression or anxiety, and this might include, in terms of anxiety disorders, generalized anxiety disorder, panic disorder, obsessive compulsive disorder as well. Within the step care model, as set out in the guidelines for anxiety and depression, doesn't tend to include social anxiety. That tends to be reserved for high intensity delivery. Not to say that all PWPs and low intensity practitioners don't work with people who are experiencing social anxiety, but it tends to focus on generalized anxiety disorder, panic disorder, and obsessive compulsive disorder. And they can be delivered by anyone who's received appropriate training and has appropriate clinical supervision. There are competency measures that we use to measure the competence of people being trained in delivery of low intensity CBT. We use one developed by the University of Sheffield in the UK that looks at people's trainees' progression from novice through to proficient and expert in the delivery of low intensity CBT. but it can be delivered by anyone with appropriate training and supervision. And it involves low usage of specialist therapist time in that way as well. Okay. Does anyone have any questions at this point? Are there any questions in the chat?
There's none in the chat.
Okay. Good. Okay. So I'll move on then to just start to think about the kind of assessments that we might want to undertake to understand the problem, and starting to work in that patient and client-centered approach, and including a collaborative approach in our working and in our delivery of low intensity interventions. This is just to give you an overview of the kind of assessments that we might use in a low intensity service, really. It's probably something that we could spend at least a whole 2-hour session going on over. So I'm just going to give you the highlights here of what we would support people to learn in terms of assessment for low intensity interventions. So starting with introductions and session overview. So we would always obviously check client details. We would always encourage therapists, obviously, to clearly introduce themselves and their role. And that can be really important in low intensity interventions, to make sure that you explain your role as we were talking about earlier, almost a coach or a guide supporting the implementation of those guided self-help materials with the client. Okay. So setting up the expectations of what you can provide in the role as a low intensity therapist, and what you would not be able to provide in terms of counselling, for example. It's also a good idea at this point to talk about the importance of those guided self-help interventions and how they'll be used to lead the delivery of the intervention, and how they're the tool really for the patient to work with, to learn the skills with your support to manage their symptoms. And that process involves quite a lot of self-work, or between session work, homework as some people might call it, on the behalf of the client within and between the sessions. So it's important to let people know that this isn't the kind of therapy that people are going to just be able to come to the sessions and not to do any work themselves in between, that there will be some commitment to building these skills and practicing these skills in between sessions. So it's worth setting that expectation out at the start and exploring any barriers that clients might face in doing that, and helping them to then think about how to overcome those barriers to make sure they can get the most from treatment. We'd always talk about confidentiality, and obviously that may be different in different settings, but it's something that should be explored, and you should be very clear about in terms of what information will be kept confidential in sessions, and when you might need to share information with others. For example, if there was a risk to the client or a risk was identified to other people. And we would very clearly set an agenda for low intensity sessions. So as well as being shorter in number of sessions, 6 to 8 sessions, treatment sessions also tend to be shorter than you would think of as traditional counselling session or psychology session, which are sometimes around 50 minutes. Low intensity treatment sessions tend to be much shorter, often around 30 minutes, although there may be some flexibility in that. For example, when working with people with long-term conditions, you might have sessions that are a little bit longer, perhaps up to 45 minutes, or you might indeed have sessions that are shorter, but more frequent. So, for example, if someone was experiencing chronic pain, for example, and found it difficult to sit and engage in a session for 30 to 40 minutes, you might have shorter sessions. But very important to explain that and set people's expectations from the start. We'll then move into an information gathering phase to make sure that you can elicit all of the information that you need from the client to be able to understand their problem and develop a shared understanding of the problem that they're experiencing. So we would be asking about the problem they're presenting with, what's brought them here to see you today. And we'd be looking to identify what the key physical, behavioural and cognitive symptoms of the problem that the client's experiencing are. We'd of course be doing a risk assessment to identify any risk of suicide, any risk of self-harm, any risk to other people, and also any risk from other people. And that's a very important part of every session. So it would be done thoroughly at the assessment and also reassessed at each session as well. And then we'd be looking to identify the impact that the problem they're experiencing has been having on home life, work, relationships, social life, and any personal activities, hobbies, for example, that they would usually be engaging in that they may have stopped engaging in as they've been feeling depressed or anxious. And then once you've developed all that information, you'd be looking at then giving the clients some information back about the problem that they've described to you that they're experiencing and helping them to understand that problem using what we call conceptualization or formulation, which is around the ABCE model, which I'll go into a bit more detail about in a second. And then following that, you'd be looking at developing a shared plan for the sessions. So this is where that collaborative element really comes in. You'd be summarising the problems that the client's experiencing in a problem statement and setting some goals, asking them what it is that they want to change, what would they like to achieve from attending these sessions, and then together planning how you would do that over the next 6 to 8 sessions. That just gives you a brief idea of what may be included in a low intensity CBT assessment. It's a lot to get in. Our trainees, when we're looking at training people to deliver low intensity CBT, have to do this in about 45 minutes. The clients, there's a lot to cover, but it is possible to do, and it can sometimes be split over a couple of sessions if necessary. So just to kind of go into that shared planning and decision making element in a little bit more detail. At the end of the assessment or after the assessment, you'll be aiming to develop a shared understanding of the presenting problem that the client brings to the session and agreeing a way to move forward together. And this process usually involves developing a problem statement, setting goals, and using the ABCE model to develop this shared understanding and agree your way forward. So we'll start off just having a think about the problem statement. Problem statement is a statement that is written between the low intensity therapist and the client, so collaboratively together, but led by the client really, that summarises in probably 3 to 5 lines or sentences, so quite short, the problem that the client's been experiencing and how it's impacting on them. It's designed to be a record really and to ensure that both you and the client have a shared understanding of the problem and that you're clear and they're clear that you're agreeing what you're working on. It starts to shift the focus of the discussion from your fact finding during the assessment to becoming collaborative effort between you both. It's a reference point for future contacts between you and the patient to review how things are going, to think about change. So as sessions progress, you know, when you review that problem statement at the beginning of each of your treatment sessions, is this still the way that you're feeling? Is anything changing within this problem statement? And it's also a good reference point early on to check that you're working on the correct problem as well. And as I've said, it's one way of evaluating changes that the patient makes and experiences during their sessions. Often, you know, within research settings and also within all low intensity CBT settings in our NHS talking therapy service, recovery will be measured using patient-reported outcome measures, like the PHQ-9, the GAD-7, for example. But this is one way of evaluating change at a more patient-centered level and what's changing in the problem statement that they initially set out for to work on during the sessions. So the problem statement includes generally 4 key areas. So it's a brief summary of the main problem, which includes information about the trigger. So what provokes the problem, including any context of situations, time, and people. It includes a description of the main problem, which might include the physical, behavioural, and cognitive aspects of that problem as well. Impact, so what are the consequences of the problem, the depression and anxiety for the patient, and usually ends with goals. So usually ends with a broad goal for treatment that we might go on to refine a little bit more afterwards. So just to give you an example of a problem statement, so something about the context, the trigger here. So I've been feeling low for the past 4 months since my relationship ended. I feel worse in the mornings when I ignore my family. Summary of the problem and the symptoms they're experiencing. So I can't concentrate and I'm struggling to stay asleep. It's getting harder and harder to work and I've stopped answering the phone to my friends. I think I'm a failure. So that includes some of the physical symptoms they're experiencing with lack of concentration and poor sleep, some behavioural symptoms they're experiencing. So finding it hard to go to work, avoiding phone calls, and some cognitive negative thoughts there and thinking that they're a failure. Impact, so I've lost contact with my family, friends, and I'm struggling to meet targets at work. And broad goal, I want to stop feeling like this. I want to start meeting my family for meals again, and I want to deal with the issues at work so I don't feel so overwhelmed by pressure. So this is what a problem statement might look like and would be reviewed at each session with the client to identify changes as they may happen over the course of treatment. Once you've developed a broad goal within the problem statement, you might then look in more detail at goal setting. So just to ask people a question about their own experience of goal setting. Would anyone like to share, anything in the chat, or please put your hand up about what their experience is of goal settings? Might be personally, it might be at work, it might be in supporting other people with anxiety and depression, and anything that was easy about it or anything that was difficult about it. No, can't see the chat.
May I say something?
Yes, of course you can, yeah.
Okay, so one thing that I found that a lot of clients find it difficult to concretely create goals when it comes to them coming in with anxiety.
Mm-hmm.
Because for them, I think the overarching goal is for the anxiety to just go away. And when we are trying to ask them to concretely jot down a goal or even reflect on that collectively, they are really, I think, quite a lot of times they're at loss. And they go like, we really don't know. There's only one goal that we just want the anxiety to go away. But there are so many other factors attached to the root cause of anxiety that this becomes a very generic goal. So then we really have to kind of work with the client to categorically break that main goal down to smaller goals. But I think that's one thing clients find really challenging, at least in my experience.
Yeah, I agree. I think people would say, well, I want this anxiety to go away. I want it to stop. I want to feel better. So in that situation, do you have any idea what kind of questions you might ask to help the client to set a more specific goal? Something that can be directly worked on within session.
Maybe Amy, around changes that they would want to see in their life if that anxiety goes away. So based on those changes that they would want to see in their life, in their anxiety-free life, can help us to think about these specific goals.
Yeah, thanks, Toby. Yeah, absolutely. So one of the things that I might ask, and Karina, you might want to jump in as well here. If someone said they just want the anxiety to go away, the anxiety to stop, to try to make that more specific goal, I might ask people, so if you weren't experiencing anxiety, what would be different? What would you be doing differently to help? So they may say, well, I'd be going to work, I'd be having dinner with my family, I'd be spending time with my friends, and then working on that to kind of develop some specific goals. For example, speaking to friends on the phone a couple of times a week, or going back to work, for example.
No, absolutely. And I would say a similar thing. So what is it that would be different or that you would be doing if you hadn't got this level of anxiety?
Yeah.
So I'd be saying, look, that's a great goal, even though it's not, that they want to get rid of their anxiety. But I'd be saying, well, perhaps we want to specify that a bit more. What is it that what would you be doing differently if you hadn't got this level of anxiety?
Yeah. Thank you. Yeah, those questions can help us really to make sure that. Oh, was someone speaking? Oh no. Those questions can help us to make SMART goals, which I'm sure many people have heard of before. But SMART goals are around making sure that the goals we set with clients again, and I want to deal with the issues at work so I don't feel so overwhelmed by pressure, which was obviously at the end of our problem statement from before. So we would think about asking those questions that we just discussed to make the goal more specific, more measurable. So thinking about meeting family and friends for meals again. So we might ask, how often would you like to be doing this? Who would you like to be meeting? Where would you like to be doing this? To make a very specific goal for the client to be able to work on that we can measure. We might also think about what the barriers might be to achieving that. And we might set a time frame. So within the next couple of weeks, I would like to be meeting my sisters for a meal once a week, for example. Okay. So when we've got our goal, we then need to think about how we're going to get from where we are now to achieving our goal. So if we think about A as where we are now and B is achieving our goal, and you can see here that it's not always a straightforward path when we're experiencing depression and anxiety to get from where we are now to achieving our goal, because the path tends to be I can't think of the word there, but the path tends to be tangled up in a way by the symptoms that we're experiencing. So if you look here that in the bottom picture, we've got where we are now to where we want to be, and in the middle, this kind of ball of string is completely tangled. And that would be representative of the symptoms that we're experiencing, because that's what it can feel like, can't it? You know what you want to do, you know you don't want to feel this anxiety anymore, but you're experiencing these physical, cognitive, behavioural symptoms that are making it very hard for you to move forward and keeping you stuck in the middle. And what we want to do in this situation is try to tease out what's going on within those physical, cognitive, and behavioural symptoms that's stopping us from reaching our goal. And the method that we use to do that, often in low intensity interventions, is with a model called the ABCE cycle, which is quite a straightforward way of understanding how our physical symptoms, our behaviours, the things that we do, and our thoughts, the negative thoughts or the anxious thoughts we might be experiencing, can work together to keep us in a vicious cycle that prevents us from reaching our goals. So we would encourage people in low intensity interventions to work with the client to think about what each of these different categories of symptoms are. So thinking back to the problem statement, we'd be looking at what's going on in the environment. You can see that there on the left-hand side, the environment or the trigger. We'd be looking at asking them what their physical symptoms are. So if someone's feeling depressed, for example, they might be experiencing poor concentration, reduced appetite, difficulties getting to sleep, or early morning waking. They might be experiencing fatigue, many things that people might be experiencing physically within their bodies when they feel depressed. As a result of that, they might find that their behaviour's changed, that they're doing less than they used to do. They're perhaps not doing their routine jobs around the house. They're not keeping on top of looking after themselves, perhaps not looking after other people the way they have been doing. They're not engaging in any of the pleasurable activities and hobbies, for example, that they normally enjoy. They're not socialising. They've stopped or started doing things because they're feeling down and low physically. And you find that when people experience those changes in behaviour, it has a knock-on impact on their thoughts and cognitions. And thoughts and cognitions can become more negative. People can think that they're not achieving what they should do. They're failure. And think very critically about themselves. And then, of course, the more that we experience those negative thoughts and cognitions, the worse that we feel physically. So our low mood will increase, our sleep may be impacted even further, we're likely to feel more fatigued, perhaps have less appetite or even increased appetite. That would be common, and then we end up in a vicious cycle. And what we want to do with our low intensity cognitive behaviour therapy interventions is break this cycle. So we would look to understand this cycle with a client and then think about which interventions we have at our disposal that can help to break this cycle for the client. And the client would then be able to think about where within this cycle they'd like to work and which intervention with our support will be most helpful for them. So there's a guide, let's move forward, of recommended low intensity CBT interventions for different conditions. So you can see here, I've listed the disorders across the top here. So we've got depression, simple phobias, agoraphobia, panic disorder, generalized anxiety disorder, and obsessive compulsive disorder. And down the left-hand side, we've got examples of the different low intensity CBT interventions that are recommended for each condition. So once we've understood the client's presenting problem, we can think about which intervention is best suited. So you can see behavioural activation here recommended for depression, as is cognitive restructuring, as is problem solving, as is sleep hygiene, and as is exercise and physical activity. And then you can see further on for the anxiety disorders, which interventions are recommended. So having this in our mind as practitioners of which interventions are helpful and evidence-based for different conditions, we would then think about on the ABCE model where they work. So looking at a few examples here, we can see where these interventions can intervene, if you like, to stop this cycle from maintaining itself. So we have those lifestyle interventions that I'll talk about in a minute that can be very helpful for addressing physical symptoms that the client might be experiencing, and working on some of those may help to break the cycle. We have several interventions for different conditions that may work in the area of behaviours. So behavioural activation, which we're going to talk about later on. Worry management for people experiencing generalised anxiety disorder, and problem solving, which can be used for people experiencing both depression and anxiety. And then if somebody wants to work on their unhelpful thoughts, their cognitions, we have thought challenging or cognitive restructuring that people can use to do that. And during the process of 6 to 8 sessions, clients might engage in one or more of these interventions with your support. So we're going to have a look now, just keep an eye on the time as well. Just go for, perhaps do lifestyle intervention, and then we'll have a quick break and come back for behavioural activation. Okay. So we're going to go through these interventions listed here to give you some examples of how they would be delivered in the low intensity format. So the first is the lifestyle interventions, which you said would work particularly on the physical symptoms that a client might be experiencing for anxiety and depression. And these might include physical activity and exercise. So we know that there's an excellent evidence base that increasing our physical activity and exercise can prevent depression and reduce symptoms of depression as well. So it's something that we're encouraging more and more within low intensity interventions. And there's actually been a specific guided self-help book recommended now within low intensity interventions to work on this in the course of the sessions. It can also be incorporated into other interventions like behavioural activation, but it can be used as a standalone as well. We might talk to people about things like if people drink a lot of tea, a lot of caffeine, reducing caffeine if they're experiencing high anxiety, problems with sleep as well, and talking to people and giving education around how caffeine affects us and how best to kind of reduce that, and if you're going to drink caffeine, when to drink it, that might have less effect on sleep, for example. Reducing any alcohol use or any drug use might also be a priority if the patient is involved with using drugs at all, drinking alcohol. Maybe around smoking cessation, if somebody's smoking. Sleep hygiene would be included in this as well. So thinking about how to set up a good night's sleep and how to get into a routine with going to bed and sleep that can help promote being able to get to sleep and also stay asleep as well. And there may be issues and discussions around medication management. If someone's taking any medication, antidepressant, for example, there may be discussion around how they're finding that, if they're taking it as prescribed, if they're experiencing any side effects, and if they are, that might involve discussion and collaboration with the medical professional who's prescribing that medication for them. So sorry, I've got a question here at the bottom about the Indonesian context. Obviously, I'm not going to ask you about the Indonesian context, but thinking about lifestyle interventions, are there any of these that you feel are most important context, and how might they be implemented? Anyone have any ideas? Oh, sorry. Oh, you can't see the chat and it just moves the slides. Okay.
So somebody's put something in the chat. Jill saying, I believe exercise to be the most important, but most difficult to implement in the longer term, in the longer run as well. So, Jill, I wonder if you want to say something about that. Why do you think it's most difficult to implement?
Okay.
Yeah, so it's what Jill was saying is it can get mundane and difficult to get
Mm.
immediate results um
After a while.
after a while.
Yeah.
Yeah, so yeah, I think that's absolutely true. So what you've got to do is do something with the exercise. So uh, so you could say going for a walk every day, but for some people that might not be meaningful. It might be going to a local shop every day or walking
Hmm.
to the shop. It might be walking to visit family rather than necessarily getting transport. So what your role is to make this meaningful for the individual.
Mm. I think it's important to think about that not everybody is wanting to or ready for formal exercise as well. And it's about activity, movement throughout the day, increasing that sometimes as a starting point rather than. I think people often get put off by this as an intervention, thinking, well, they're going to make me go to for a run or go to a gym class or go to some kind of formal intense exercise, and that it's not always about that. It's generally
Yeah.
increasing our daily movement first.
And somebody else has put perhaps physical activity and exercise, reduction of caffeine and sleep
Mm,
hygiene is the most important. I actually think they're all important, but if you asked me to reduce caffeine, I probably wouldn't. Yeah, I would do some exercise. So I think as Amy had said earlier, what you need to do is to be collaborative with people.
mm,
What do they think will help them?
yeah,
Bill's
yeah.
put something about smoking cessation is also difficult to implement as they try to reduce it, but they still need more support around it. And yes, I would agree with that. So if there are any um, national or local programs
Mhm.
um, to help people, there's things on the internet. There are various ways that you can do that. I think you're right that telling people just to stop smoking is actually probably not going to help them. They're going to want some more support than that.
Mm,
So thank you very much for that comment.
thank you. Okay, so we've got done about an hour, so shall we take a 5 minute break and then we'll come back and look in more detail at some of the other interventions? That sound okay? So if we come back at 5 past,
Hmm.
is that okay with everyone?
Yeah.
Yes, Dr. Amy.
Good plan.
Brilliant. Okay, I'll reshare the slides for us. Go.
Will you move the slides?
Yeah, I'll move them if you tell me when you want me to move them on. And then just let me know when you want me to come back in.
Yeah. Shall I do BA and cognitive restructuring?
Yeah, that's fine.
Yeah.
And then I'll pick up the next bit. Yeah. Fab.
Hi everybody, my name's Karina Lovell and I'm really sorry I was so late because there were so many of you in there, they wouldn't let me in. So but then Tabor sorted it out. Is everybody back? Do we think? Yeah. Well, I'll start. So, one of the interventions that probably works around the behavioural activation, though it will go into the other systems, such as the autonomic and the cognitive or thoughts, is behavioural activation. And a simple way of explaining this to people is following your plan rather than your mood. So, when we're depressed, we often follow our mood. So we'll often perhaps stay in bed or we won't go out because we don't feel well enough. And what this is about behavioural activation is activating ourselves to follow our plan. And most of us, if we're not depressed, will do that. So we're all here today. We'll often follow our diaries and we're able to follow our plan. But actually, when we're low, it becomes really difficult to follow our plan. And therefore, what we end up doing is following our mood. Can I have the next slide, please, Amy? So if we do, the less we do, the more we feel depressed. Like our mood activity, our activity changes our mood. So we do less activities, we get more feelings of depression. We do less, we get more feelings of depression. So the less we do, the more depressed we feel. The more depressed you feel, the less you do. So it's like a bit like this sort of vicious circle. Can we have the next slide, please? So when we think of activities, so a number of years ago, people always thought about bringing pleasurable activities in. And actually, we've stopped that now and said that there are different types of activities. There are things that are routine for us, like washing, might actually be cooking, cleaning, our own personal hygiene. There are necessary activities, which are going to work, paying bills, food shopping, childcare. So they're the sort of necessary ones. And then there are a third group, which is the pleasurable. So these are things about seeing our family and our friends, the things that we do. So these are the types of activities that will ask people about. What are the routine things that you're doing? And what are the necessary things that we're doing? And what are the pleasurable? Some people might find it difficult to think about necessary. So what we'd probably say to them are, what are the things that are really important that you do? So, for example, paying bills, going to work, i.e. to get money, childcare, they're all necessary things. Can I have the next slide, please, Amy? And if you like, there are 6 stages of, if you think about following your plan rather than your mood, we need to explain what BA is. So we need to explain and be clear about the rationale and using people's personal experience to do that. So really what we're saying is, well, when you're depressed, we tend to do less. We feel a lot less like doing anything. Sometimes our thoughts come into this about people won't want to see us, people won't want to spend time with us. And what we need is a baseline activity diary. And often people will say, well, I'm not doing anything. And we're saying, well, what would be helpful is just to ask you to do a diary, which we'll show you an example of in a minute, just to find out exactly what you are doing. And then we can work from that. And then what we're doing with people is identifying the routine, necessary, and pleasurable activities that they're down. And often with people, there won't be those pleasurable activities. They won't be visiting their family. They might be doing some routine and some necessary. And remember that this depends on the severity of depression. Like occasionally people are doing, in fact, nothing. They've just taken to their beds. But usually with sort of mild and moderate, they are doing something. But what they're probably not doing is their pleasurable activities. And then we're saying to people, well, make hierarchy or a ladder of the routine, necessary and pleasurable things, activities. So what we're saying is, which of these things is most difficult for you? And which are the things that are easier? So people will often say, again, that their routine activities are easier than pleasurable activities. Not always, but generally. So what we're saying is, can we order these into, if you like, a ladder or some sort of hierarchy, starting with probably the easiest things first? And then what we're saying to people is, let's try and put a few more activities into your diary and plan some of each activity type for the following week. So what we're saying is, you know, what are the routine things that you'd like to increase? And that might be things like cooking or doing something a bit more complicated, or going to visit their family, or ringing their family, or talking with their family, or going for a walk with their family. And then what we're doing is implementing those activities. So what we need to do is to try and put people, if you like, into a win-win situation. So we're not setting out those difficulties, those activities as too difficult to start with. We're starting with some relatively easy things. And then reviewing that progress together each week. So what we're then doing is looking at the diary, asking people how they got on with it, what problem solving with them, any difficulties that they found, because usually this isn't plain sailing. People will have difficulties. They'll say they're unable to do the task because they felt so low. And I think you can say to people, well, do you think you'd feel lower or more depressed doing this than if not? And often that answer is no. So what we're saying is, because sometimes people will bring in levels of enjoyment. I don't initially. I'm just interested in them activating their mood and activating their cells. And using very much that statement about following their own plan, not their mood, and how difficult that can be. Because if you think about this morning, when you got up to come here, you didn't think, I just so want to get up. I'm so excited about this session today. What you thought was probably, I'd like another 10 minutes in bed. And if you'd have done that, that would have probably been about following your mood rather than your plan. So we get up. So, and It's a very collaborative intervention. It's a very simple intervention. It's a hugely effective intervention. But actually, the application of it is more difficult. I'm just going to stop there for a minute to see if anybody's got any questions. Thank you, Alan. Okay, so let's move on to the diary. Remember the next slide. So this is a sort of baseline diary, and we try and keep it fairly simple. So we'll often talk about morning, afternoon, and evening rather than doing an hourly one, but just saying, you know, what, where, when, and who, or what are they actually doing. And what this diary does, it can help you to see how the client is spending their time. It gives you something to work from. And I guess it's not needed with all clients. So often I think it is because people say, well, I'm doing nothing, but actually they are doing something, even if they're just in bed or they're just watching television. People are usually doing something. So we can say that it's not needed with all clients, but what I would do is urge people to actually try and get a baseline, because it can help people when they start doing things to look back. Though the negative side of it is that people will say, well, I told you I weren't doing anything and not doing anything. I'm not sure I'd buy that too much, because I think some people are doing something. There's few people who are just lying in bed all day. Can I have the next slide, please? Please interrupt if there's any questions. And then, as I said, we wanted to do that ladder or that hierarchy. Yeah, so Samia has said that activities that bring in a sense of achievement can be important to add. I would probably put meaning rather than achievement. So activities that mean something to people. And so what we're doing here is doing this listing and rating the activities in terms of the easiest ones. And like the easiest ones for this person, playing sport, and the most difficult is actually paying bills and cooking. So what we're asking people to do is to make it this list and rate their levels of activities. And what we're trying to do is include routine, pleasurable, and necessary activities through the list. Because what we don't want is all routine activities. Sorry, I'm just trying to read the comment. So, and it sometimes it can make people feel more anxious to do things. But actually, what we're doing is we're saying, well, what steps do you feel that you can start with? We're not putting our own view onto people. And so our activity is the only thing that bring change in behaviour. No, they're not the only things, but they're probably quite important things. They're sort of behavioural things. We'll often see a change relatively quickly. And I think what we can say is that at the very least, people don't feel worse for doing them, and they often feel better for doing something, because it either gives them a sense of achievement or some value. Can I have the next slide, please? And now then that we have this list of activities from easiest to hardest, you can plan which ones to start doing each week. So we'd start with one of the routine, necessary or pleasurable, and starting with the easiest first, and using the diary to plan them in. And we've got another slide with diary on in a minute. And then what we do is each week we see them, or that we ring them, or we have a interaction with them. What we're saying was, how did you get on? Problem solving difficulties. So if they couldn't do it, what were the things that stopped you being able to do that? And actually working with people. We have the next slide, please, Amy. And so this is a simple activity diary, so that people can have this on their phone, they can have it in a written form. Often people don't like paper things, one, because they lose them, or if somebody sees them. So, but this could easily go on the phone, and people would fit this in. The next slide. And then some, I guess, some of the sort of typical or common problems. An increase in activity is going to be hard. I guess that most people here have had a day or a few days or a few weeks where they felt low, depressed. It can actually be really difficult to increase those activities. And starting from cold when you feel low takes lots of energy. And I guess the tips is being collaborative, starting small, making sure to include some pleasurable activities, thinking smart, and thinking about the car analogy that I'm actually going to let Amy talk about, because I'm not sure I sort of quite get that one. And obviously following your plan and not your mood. So Amy, do you want to talk about the car one?
Yeah,
So
let's see if it makes sense to people. So this is what I was taught when I remember being taught about behavioural activation at first, is that sometimes when it can be very hard, obviously, to start an activity, but when we get going into an activity, we find that often our energy increases a little bit and we're able to do a little bit more than what we thought we would. And this is like the idea of if your car is stopped and you need to give it a push start. So there's a lot of energy that goes into giving the car a push start, and it sputters and starts for a bit as it goes along the road, but eventually the engine will kick in and it will get going. And this is the idea around doing a little bit of activity, while very difficult to get started, can actually increase our energy and our motivation, similar to how it would work with giving our car a push start, if you like. Now, I'm told by a lot of people that this doesn't work anymore as an analogy because of electric cars and different things like that that we've got now. However, I think I feel like it still doesn't. It's something that I always think about. You may find it completely unhelpful, but it's something that I always think about in terms of reminding myself how putting a little bit of energy in can often breed and enhance more energy as we start doing something.
Thank you. I knew I'd get that wrong if I started on that one, just because I don't drive. So
I hope that was somewhat sense to people.
Can we have the next slide, please? So just before we go on to cognitive restructuring, behavioural activation, it's about following your plan rather than your mood. It's a simple but very effective intervention. The application of it is the most difficult thing, and you need to work collaboratively. So are there any questions that people have got about behavioural activation? No?
No,
Okay.
can't see anything.
Okay. And let's then move on to cognitive restructuring. So again, a simple way of saying this would be changing, evaluating your thinking. So this is recommended as a low intensity intervention for depression, panic, some OCD and simple phobias or straightforward phobias. And it involves working with people to identify and challenge negative or maladaptive thoughts. So can I take the next slide, please, Amy? So if we think about our thinking, we'll all have some unhelpful thinking. And we'll often talk about our automatic thoughts. These are ones that come in fairly simply. The rules and assumptions that we live by, and then our core beliefs. And usually high intensity CBT works more with core beliefs and some of our rules and assumptions. Low intensity, it sort of works more with the automatic thoughts, but we'll move into the rules and assumption. So I'm just reading this.
Yeah, I think the question about, we were saying that people with mild symptoms might still be engaging in that, they might still be working, they might still be engaging in everyday tasks. So how would we define behavioural activation at that stage?
It might be about doing more meaningful activities. So often people will have stopped their pleasure activities. Often people we see, they'll have stopped perhaps going to the gym, they've stopped walking, they've stopped seeing friends, they've stopped contacting friends. And what they're doing is just their routine activities. And I think if you remember in life, we actually need a range of activities. We did the same thing every day. We'd probably end up feeling either very bored or we'd actually end up feeling sort of low. So, and what we're also looking at is meaningful activities that give us some meaning for life. So thank you, Hania. Okay, so we just go back to the cognitive restructuring. So more in low intensity, we're looking at automatic thoughts. We do get some overlap in terms of rules and assumptions and some core beliefs, but it's more the negative automatic thoughts. And then with high intensity, we're often looking fairly directly at core beliefs. Thank you, Amy. I wonder if I could have the next slide. So what are negative automatic thoughts? Like I wouldn't use negative automatic thoughts to a client. What I'd talk about is unhelpful thoughts. And if you think about our unhelpful thoughts, like we're not happy all the time, we're not happy with the way we look, we sometimes or occasionally we think we've got an imposter syndrome. And one of the things is that these thoughts, they pop into our head nearly automatically. So, for example, I might think I don't look very good today. And they're often, if you like, distorted. They don't fit all the facts. But actually, when we have them, that doesn't matter. It doesn't really occur to us that these thoughts don't fit the facts, because I look no different to what I did yesterday. Okay, so I'll have a thought, I look terrible, I look awful, I look fat or whatever. It pops into my head, it's distorted, but I ignore those facts that actually I don't look any different to I did yesterday. They're unhelpful in they make you feel low and makes it difficult to make a change. And they're plausible. The problem is we believe them. So often, particularly in academia and clinical work, we think we're not good enough. But we have this thought, we're not as good, I'm not as good as Amy in terms of clinician. It doesn't matter that it fits the facts. They make me feel low, but they also probably evoke a number of other emotions. But what I absolutely do is believe them. If this is an entirely plausible thought that I'm nowhere near as good as Amy in terms of my clinical work. So this feels entirely plausible. I'm also, though, not as good as other people who are clinicians. So it's not probably just Amy, it extends to other people. They're very difficult to switch off. And one of the reasons they're difficult to switch off is because we find them really plausible, really believable. And they can be words or images. So what I'd like to ask you as a group is the types of thoughts that these would be. So try and think of the types of thoughts that you've had, that lots of other people have, that's a negative automatic thought. What sorts of thoughts? Unless you're all dead happy and not depressed, because even when we're not depressed, we'll have these thoughts. We just don't have them at the same rate or the same intensity as people who are depressed. Rajil, I'll come to your comment in a minute.
So one is Rajil saying, I may have failed because they were better instead of me not being as compatible to a situation.
Yeah, so often I'll have things that people have failed or they're not good as or whatever. So, yeah, there's no real difference between automatic and involuntary. That what we're saying is these thoughts just come, they're just there, they just pop into our head, and we accept these as the truth. They're the truth. We don't question them. Yep, so Ace is saying I might not be able to complete the task, that again, so I can't do this or meet up the deadline. These might be automatic thoughts and probably are. Yeah, so this one by Hania, I'm sorry if I'm not pronouncing these names right, I'm trying. I'm never kind enough, like other people. But what all these thoughts are doing is they've just popped into the heads. They don't fit the facts. They're unhelpful, but we believe them. Okay. And these can be words or they could be images. And that's sort of quite important. So thank you for that. We have the next slide. One of the things that we want to do is to find out what these thoughts are. They're automatic. They actually can be quite difficult to catch. And but again, asking people to monitor these either using a recording sheet, paper one like that, or we can put them on the phone, or there's loads on the internet that we can use. But what we're asking people is try and catch some of them. So I might say, well, when you get one that you can catch, see if you can, or I might give them people time periods. So I might say, try and watch out for them for half an hour in the morning, half an hour in the afternoon, half an hour in the evening. Because actually to catch all these would be nearly impossible because they often sort of flit through. We don't actually do a lot with them except believe them. And what we'd ask is to say to people, what were you doing at the time? And I might put, well, I was getting up, I was getting ready for work, and rate, and then I might say, well, how were you feeling? I was saying I was feeling perhaps a bit low, a bit anxious, and I would rate then how that what I was feeling. So I'd probably put about 30 or 40% because I'm depressed. And then I would rate how much I believe that thought. So it would be, I believe the thought that I was ugly, or I was fat, or I wasn't as good as other people at the job, I couldn't do it, is probably actually quite high. So that would probably be about 50-60%. So what we're asking people to do is to record them. So we're not asking them to change them at the moment or evaluate them in any other way. What we're just doing is getting a recording. Thank you. Can I have the next slide, Amy? And then what we might do, though this isn't essential, is we might think about what are the thinking errors people are doing. So often we'll, and these are just some of them, but exaggerating. So exaggerating problems and the possible harm they could cause. Overgeneralizing, making a broad general statement that emphasizes the negatives, such as nobody likes me. Or every time I do this, this happens. So I catch the bus in the morning, it doesn't come at a particular time, it comes about every 10 minutes. And because they're so frequent, I nearly always miss one. And what I say is this always happens to me, I always miss the bus. There's no intention of catching that particular bus. So that's that sort of an overgeneralization. We often ignore the positive. And we often remember any negative events. So we see a lot of students, myself and Amy, and other people who are lecturing, where they'll say, you know, they've got 91%, and they'll say, well, you know, and you'll say, well, you can improve this, not much, but you could improve it by thinking about perhaps your reference style. And that is all they take away from it, is they've got problems with their reference style. Never mind, they've got 91% and they've done a brilliant piece of work. And so that ignoring the positive. And pessimism, believing that negative things are likely to more likely to happen to them than positive things, and they're less likely to happen. And blaming themselves, thinking that negative things that happen are always and entirely your own fault, and not giving yourself credit, thinking that positive things that happen are either always just luck or somebody else is doing and never the result of your own efforts. And there are lots of these types of, if you like, thinking errors. So one of the things that I think is a really common error is people believing that things will change. So if they believe they're happy or think they're happy, something else will go wrong, bring them down. And that is a sort of, so people will often spend far more time on the negatives or the things that could go wrong than actually on what is actually happening at the moment. So there are all these errors. So if people are can do this, then and they can be really helpful for people. Other people, I don't think they are. So what you need to do is to work out whether, you know, you can really see by somebody's face fairly quickly whether they find this helpful. But just, you know, and if you can't, just to say, look, there are errors in people's thinking, and just give them one or two examples. But if people are, to understand them and to identify what are the thinking errors that they have. So what ones do you think are the most common? And if we just look at this list, which are the ones that you find yourself doing or you notice in other people?
We've got overgeneralizing and ignoring positives.
Yeah. So, and they're all sort of quite common, but I think the sort of overgeneralizing, ignoring the positive or not giving yourself the credit are the ones that are most likely to happen.
Uh-huh.
I wonder if I can have the next slide.
You can. Yeah. Okay.
And then what we might say for people, because we're not saying, look, don't be silly, that's a ridiculous thought to have. What we're saying is, let's evaluate this thought to see if there's any truth there or not. And sometimes we describe this as taking a thought to court. So we have defense and prosecution. And what we're saying is, all we're going to do is just look at this thought to see what evidence you have and what evidence you don't have. So often we'll say, you'll say to people, well, what makes you think this thought's true? And they'll come out with a whole load of things like, I might think, well, I'm not intelligent enough. So, and if you said to me, well, what are the thoughts that make that not true? Or make me feel that that's true, I might say, well, I didn't go through the traditional university system. I did my degrees part-time. Or I might say I don't follow conversations as much as other people. I might say, well, don't know what else I'd say, but possibly I don't articulate myself very well, but I'd come out with all these things. I have a great big long list. And then if you said to me, well, what are the things that don't make this true? And I might say, well, there's nothing. Okay, and what then would you say to that? If I say, well, there's nothing that makes this thought not true. What are the things that you might say to me? What are the questions that you might ask that might help me balance this thought? You might ask me, well, what qualifications have you got? Just tell me what your qualifications are, and I'd reel off these qualifications and say, well, is that something that we might put in to counteract this thought? I've got a PhD, I've got a first degree, I've got a master's degree, I've got whatever. Okay. And then you might say, well, is there anything else? And you might say, well, so you're doing this sort of Socratically, you are saying, think for a minute, what are the other things that make you think that you're not less intelligent? And I might say, well, I've won various awards, or I've come first in a couple of exams, or whatever. And so what I'm trying to do is to build up this other area, but what I'm trying to do is to build it up from the person's point of view. I'm not saying it. I'm just asking them questions. And then what we're saying, so I believe this thought probably 78%. And at the end of this, you'd say, so we've got 7 things on the right making you think this is true. We've got about 5 things that makes this less so. Then what would you rate it as now? And I might then rate it as not 0, but probably about 40%. And there are a whole number of questions that we do. So, is this thought an example of a thinking error? If my friend or family was having this thought, what would you say to them? And if your belief rating, so few people will say that they believe at 100%. So people will say, well, I believe it 90%. And if you then say to people, well, 10% of you didn't thought, perhaps this thought wasn't as true, what evidence made up that difference? So I'm just going to read Jill's text. Yeah, so some people do often attribute these proofs to external factors. But they can also be things like emotions. So they don't always have to be external factors, they can be internal factors. Can I have the next slide, please? And so what we're doing is trying to find a more balanced thought. So we've weighed up the evidence to think of an alternative, more balanced thought. So the thought might be, well, sometimes I feel like this, but it doesn't necessarily mean that it's factual, or on the whole, I'm a reasonably intelligent person, if that's what I was doing. You know, what feeling is associated with that new thought? So the feeling would be, I'd probably be feeling a bit better. I'd probably be feeling a bit happier. And what rating would I give to that feeling? So, you know, again, this is simple. It's a straightforward technique. It's much harder, the application of it. Can I have the next slide, please? I think that might be.
Yeah, the next slide's a exercise, but I'm not sure we've got
No, we're
time
not.
to do it.
It's 1:45.
Yeah.
But if you can do that outside of this, identifying one of your own examples of an unhelpful thought, thinking, if you can, about which thinking error it represents, and what's the evidence for and against this thought. And if you get into difficulty, use those questions and generating a more balanced alternative thought. So really simple techniques, these are hugely effective. It's the application that's most difficult. And the thing that I would say is be collaborative. Don't tell people what to think. Try and draw it out of people. Thank you.
Thanks, Karina. So I'm just going to spend a couple of minutes talking about managing worries and how we might deal with those within low intensity interventions. And then we'll have a few minutes for questions at the end. So the fourth intervention we wanted to talk about today is around identifying and managing worries and problems. We often call this worry management. And it's for people often who are experiencing high anxiety, perhaps generalized anxiety disorder, who are experiencing actual or potential problems. So it may be that people are very worried about things that might happen. They're having what if kind of thoughts that might be around their health, their family, their school. You know, what if I become unwell? What if talking about cars, thinking about things like that. What if my car breaks down? What if all the different things that we can think about and worry about on a daily basis? What if my children don't do very well in school? What if I lose my job? All the things we might find ourselves engaging in worry around. And worry management is about managing those worries and also identifying any practical problems that we can work on to stop ourselves from the need to worry about them. Okay. So worry is really feeling anxious or troubled about actual or potential problems. And the process of worrying is a behaviour, which sometimes I think within our low intensity interventions, people find difficult to think about because it feels like it's not a choice. And you think of behaviours as being something that you're engaging in and choosing to engage in. But the process of worrying is a behaviour, and it's something we spend with our trainee low intensity therapists talking about a lot, because what we can do to manage worry is help to change that behaviour. So thinking about worrying as a behaviour is useful, I think. But it's a behaviour that people commonly engage in when they're feeling anxious or depressed. And it's a central feature of generalised anxiety disorder most commonly. So within low intensity interventions, there's several steps to worry management. And what we would sometimes use within the guided self-help materials is a worry tree to help people decide which intervention pathway to go down to manage their worry. Okay, so you can see this is from a self-help resource, and there's a website. If you might be able to just see this at the bottom of the slide here, Get Self-Help. And if you can access that, on that you will find lots of relevant low intensity self-help materials that you can have a look at. And this worry decision tree is taken from one of those. So similar to the way that Karina mentioned with cognitive restructuring and managing that negative automatic thinking and unhelpful thinking, with worry, we might ask people to note down and notice their worries first. And we might ask people to use a diary, record it in their phone, something like that, to get a baseline really of what it is that they're worrying about on a day-to-day basis. And then we would ask people to think about those individual worries and try to decide whether the worries are practical, so things that we can act on and do something about, or are they hypothetical situations that we're not in control of? So are they those kind of what if worries that we're not in any control of, or are they things that we can do something about? For example, I'm trying to think of something useful to give as an example. So for practical worry, I know Karina was talking about getting on the bus before and saying that she always misses the bus and thinks and ends up engaging in negative thinking about it. But I was thinking, if you had to be somewhere at an appointment, at a meeting, at a specific time, you might think, what if I missed the bus? But that might be something practical that you could do something about with a plan around problem solving of how to make sure you get to where you need to be on time. Okay, so if your worry is a hypothetical situation that you have no control over, what we would do is ask people to engage in a process called worry time. So if there's something that you have no control over, we would ask people to think about setting aside some time each day where they're able to engage in those worries and try to save up those worries, if you like, for that time. We would be very specific about setting a specific time of day, a specific length of time, a specific place to do this. For example, not too near to bedtime, so that people aren't doing this before they go to sleep. And we would support people, and it would perhaps take quite a long time to put this together. This is a very kind of quick idea of it. But we would support people to use worry time to manage those hypothetical worries, and encouraging them during that time and towards the end of that worry time to let worries go. And we would talk about a number of refocusing techniques. People sometimes might call the grounding techniques, distraction techniques, to do that, to help them to kind of let the worries go and change the focus of their attention away from the worry. If the worry is a practical worry, that there's something that you can work on specifically to prevent yourself from having to worry about it, we would enter a intervention called problem solving, where we'll be looking to make an action plan of how to work on that worry, how to take action to prevent us from worrying about this situation. Okay, so problem solving. If we were to identify practical worries that we can take action on, we need to be very clear about what exactly the problem is. And this is something, problem solving is a good intervention for people to work on, I think, between sessions, using guided self-help materials for low intensity interventions. But part of the intervention of problem solving that people often need a lot of support with is really defining exactly what the problem is, to make sure they're working on the right problem. Otherwise, the intervention can get a little bit confusing. So some useful discussion within your low intensity sessions can be really helpful to identify exactly what the problem is that they're experiencing. The intervention of problem solving is integral to all types of CBT, not just low intensity CBT. It helps clients understand the links between their symptoms and problems and find realistic solutions. It can help to prevent excessive worry and can be used as part of the suite of worry management interventions. It can help to remove practice stresses and increase self-confidence and self-efficacy, and can be applied at stuck points in treatment. So it can be applied in general for people experiencing high anxiety and lots of worries, but it can be applied also where people are stuck in treatment to help people overcome barriers to treatment as well, where there might be underlying practical problems that are preventing them to progress in treatment. There are 7 stages of problem solving. So the first is what I've already mentioned in terms of identifying the problem very clearly with someone and making sure that we're working on the correct problem that's well described and refined. Then we would look at generating as many possible solutions for that problem as we can. So at that stage, we'll be asking the patient to work on identifying all the possible things they could do to solve that problem. Some of them might seem completely unachievable, some might seem more achievable, but at that stage we're not too worried about that. We'll be thinking about writing down all the possible solutions and encouraging them to make a note of them. We would then look at the pros and cons, or the strengths and weaknesses, or the costs and benefits of each of those solutions to weigh up which are most likely to be effective and which are least likely to be effective, and which are going to be the ones that are easy for us to implement. Okay, and hopefully from that, a solution will come out on top as the favoured solution to try, because the strength of that, or the pros of that solution, outweigh the potential benefit, costs, or weaknesses. So then that would help us to select a solution to try. And this should be really collaborative, which can be quite difficult sometimes. It's not for you as the therapist to tell the client which solution makes most sense. It's for you to help them select a solution by weighing up the pros and cons, the costs and benefits for themselves, and supporting them to make that decision. Once they've selected a solution, you'd be looking at making an action plan to help them to implement that solution. So that could be a very specific plan that could involve sometimes implementing solutions involve multiple steps. So it could involve planning over a number of days and a number of activities to implement that solution. So when are they going to do it? What are the steps to be able to implement that? Is there anybody that needs to help them? They need to support them in doing that. Thinking about all of those things to create an action plan for them to try out that solution, which they'll be able to go away and do, and then come back and feed back to you and discuss how well it went, if they were able to make any progress, if it's managed to solve the problem that they were looking for. And if not, you would have this list of other potential solutions already there with the pros and cons, the costs and benefits weighed up. You could select another solution to try. Okay. Steps 4 to 7, as I've just said, in terms of selecting a solution and trying it out, are repeated as needed, because it's not always the first solution that works the best, and you may need to try other things or several things before you find the right solution for a problem. So they can be repeated as required. Okay. So that was a very whistle stop of problem solving, but it does bring us to just before 12 o'clock. So we probably do need to finish there, and I need to have a quick look in the chat as well to see if there are queries or questions. So I will ask if anyone else has any other questions, and have a quick look in the chat as well. Somebody needing to leave. Thank you so much. So someone's asked, what if the person in question attributes their problems to abstract or higher authority and finds solace in a spiritual or religious factor? For
I've answered
example,
that one, Amy.
oh, have you?
Further down,
Okay.
yeah.
Fantastic. Thank you. Okay. Thank you, everyone. Rabina's asked, to what extent do these interventional strategies work on telecounselling, especially when you can't show charts, etc.? I don't know, Karina, if you want to answer that.
Yeah, we've done a lot of telephone work before and after COVID. And you probably just have to be a bit more organised in terms of sending stuff out. But you can ask people to record on the phone. People like the phone because it's probably much easier, it's more accessible, helps with things like childcare. So the intervention strategies, these are interventions that we nearly always use on the phone. And often what we'll do is prior to the beginning of a session, we'll actually send them a self-help book with all the copies of the diaries are in there. And if they don't want to fill them out on paper, we ask them to monitor it using their phone or something they feel is more private.
Yeah. Okay.
Amy, I'm going to go because I've got
yeah, we have to go. But thank you, everyone, so much. It's been great to see so many of you. And thanks for all